And then today's topic is about cystic fibrosis in Sri Lanka, clinical spectrum and principles of management, which is vital because we would like to see an improvement in patient outcomes in Sri Lanka. It will be conducted by Dr. Channa de Silva, who is a consultant pediatric pulmonologist at Lady Ridgeway Hospital for Children. And of significance, he is the first pediatric pulmonologist in Sri Lanka, and he's completed his MBBS and MD at University of Colombo with a merit. And then furthermore, he continued his specialized training in pediatric pulmonology. He's received multiple awards, such as the Young Investigator Award at the 70th International Research Congress on Pediatric Pulmonology in 2018 in Spain. And furthermore, he has multiple memberships and professional affiliations. And his research interests are pulmonary hemorrhage in children, childhood asthma, and bronchiectasis in children. So I would like to cordially invite Dr. Channa de Silva to start his lecture today. Over to you, sir.
It is free to disseminate knowledge about important clinical topics. Today we are going to discuss an important topics. Actually, it's a little bit of a neglected subject, but we are having some children, patients presenting with undiagnosed cystic fibrosis and later diagnosed to have this disease, which usually presents in later stages and end up with finally poor outcome. So this is a disease which is existing in Sri Lanka, but still we don't have much of awareness of this disease, important life-limiting condition in children, and it should be goes into the adulthood as well. Unfortunately, we don't have adults up to that surviving with this disease due to various factors. So within next 1 hour, we would like to discuss about this disease, important disease of cystic fibrosis, one of the important life-limiting condition in childhood. In 15th century, in Europe, there is a very popular phrase: "Woe to the child who tastes salty, from the kiss of a bro, for he is cursed and soon will die." So they have identified some kids with some growth failure and the salty kiss, and finally they died during their childhood, and then they thought these children have born with some sort of a curse. What is this curse? That time it has came from some sort of a heaven or some unknown thing, but later this has been identified or described in 1938 by Dr. Dorothy Anderson. She is a pathologist in USA. She is a pathologist which mainly involved in doing pediatric autopsies, and she has identified there's a disease which initially managed as celiac disease, but there are some features which shows not typical to celiac disease, with the common findings involving the pancreas as well as the lung involvement. So these children died of the so-called celiac disease. She has identified there's a specific features in their pancreas as well as lung conditions which involve cystic changes in their pancreas. And after identifying or analyzing about 48 autopsies, she has published this article in 1938, "The Cystic Fibrosis of the Pancreas and its Relation to Celiac Disease, a Clinical and Pathological Study." So this is one of the landmark publications. She has identified this disease initially as cystic fibrosis in the pancreas because of these similar changes in the lungs and as well as involved in the pancreas with fibrotic and cystic changes. This was first described in 1938. So she has first coined this term, the cystic fibrosis of the pancreas. This was the first description of the cystic fibrosis. Initially it came as cystic fibrosis of the pancreas because of this assessment of histological changes of these children who died, initially managed as celiac disease, but finally identified as separate conditions mainly focused on pancreas. But now we know it's not a disease confined to the pancreas, and now the name has been changed as cystic fibrosis. It's not only involved in the pancreas. So what is this disease? How it's happened, how it's been transmitted, and what is exactly the genetic basis of this disease? It's autosomal recessive disorders. In 1938, Dr. Dorothy Anderson identified this disease as a cystic fibrosis of the pancreas. And later in 1949 it has been identified as a genetic disorder, more precisely autosomal recessive disorder involving the mutations of the cystic fibrosis transmembrane conductance regulator genes. It's a huge gene. It's located in the long arm of chromosome 7. With this, the problem is autosomal recessive single gene disorder located in the chromosome 7, leading to mutations in the cystic fibrosis transmembrane conductance regulator gene. By now, they have identified over 2,000 mutations, over 2,000 different mutations involving this gene. It's a little huge gene, and there are different types of mutations which lead into possible cystic fibrosis. Out of these over 2,000 mutations, they have identified about 250 mutations are not leading to cystic fibrosis, or these are some sort of insignificant in the formation of the disease, but according to the development of this molecular genetics, now daily there are some new mutations being identified, especially all over the world. The mutations and the spectrum of the spread of these mutations are little different, and in Sri Lanka also it's not we are finding not the commonest mutations identified in the West. So it's an autosomal recessive disorder identified in 1949, involving the cystic fibrosis transmembrane conductor regulator gene, and there are over 2,000 mutations has been identified, leading to these mutations finally leading to this development of disease. Why this disease is developed? What is the reason with these gene mutations causing the problem? It's related to this molecule, the channel, ion channel. It's called the cystic fibrosis transmembrane conductance regulator. The gene code for this cystic fibrosis transmembrane conductance regulator, this is ion transport which located in the apical side of cell membrane, and it's mainly covering the lumen of the many important organs in the body. It's mainly a chloride channel. It regulates the chloride transport across the cell membrane, as well as it's involved in the regulation of many other channels, especially involved in the sodium channel or the epithelial sodium channel, or ENaC. So this channel is present or existence mainly in the surface of cells in the many parts of the body. It's there in the lungs, sweat glands, intestine, pancreas, sinuses, and the reproductive system. So depending on this involvement and the spread of this ion channel, we are seeing many spectrum of diseases or disease manifestations involving this same channel, defect in this same channel. The pathophysiology, the primary defect is same, but according to the organ involvement, the presentations, the clinical manifestations, the initial involvement, as well as the course of the disease and prognosis and long-term outcome are different in different patients. So it's depend on which gene is, which type of mutation is involved. Because of that, there's a wide spectrum of. So all these are related to this cystic fibrosis transmembrane conductor regulated ion transport. It's a chloride transport. It is control the iron and water content of the luminal secretions. Actually, what is happened here is it's a chloride transporter. It's a little complex process involving the many complex mechanisms through this channel, but basically it transports chloride across this ion channel. The chloride transports it depend on the concentration gradient. As we know, the chloride content is high in the within the cells or the intracellular space, and the chloride content is less in the extracellular space. So in these usual cells in the pancreas or the lungs or the vas deferens, then there should be net efflux of chloride from the cells to the outside or the lumen of these cells, because these are mainly located in the epithelial surfaces. When the chloride is moving towards outside with these electronic charges, the sodium molecule is also moving through the epithelial sodium channel to balance the charges, because the chloride is a negative, it accompanies the positive sodium chloride ion, although the sodium ion also, to equalize these charges. When the sodium is going out due to its osmotic effects, water molecule is also going down. So the final effect of this chloride transport is that when the chloride molecule is going out or into the lumen of the cells or these lumens, it involved in the for the movement of a water ion as well, water molecule as well. So the net effect is this chloride channel is important to maintain the hydration of the lumen or the secretions of or the movement of water. So it's important to keep the secretions within this lumen in a normal way with in a normal consistency. But in the absence or the malfunction of this cystic fibrosis transmembrane conductor regulator, there's an issue of making the hydrations of these luminal secretions. For example, it may be if it is happening in the airway or the bronchi, the bronchioles, then the problem is with the increased thick mucus. So mucus become more thick because the hydration of this mucus will be impaired. And then if it's happened in the pancreas, the pancreatic duct become obstructed, the thick secretions can obstruct this. This can happen in the vas deferens, it obstruct the vas deferens and leading to obstructive azoospermia, like that. So this conditions leading to various defects mainly involved in the secretory glands or the airways, which mainly the obstructions with due to thick secretions leading to all these major manifestations of this cystic fibrosis, patients with cystic fibrosis. As we know, any channel, so channels are proteins. There are various subtypes in all this, or these proteins. These are complex proteins. The formation of proteins is a protein synthesis. But the mRNA or the DNA should be converted to mRNA, and then mRNA there's a transcriptions, and then it should be translated into the polypeptide chain. And this polypeptide chain should be folded to make a proper arrangement of a channel, because there are different types of polypeptide chains. It should be in a proper way fold or make a proper channels. It's happened in the Golgi bodies, as we all know. So and then after formation of this channel should move to the luminal surface of these cells to make a final function, start their final functions. In this disease, and this is complex process, any part of these mechanisms at any site can be affected. It might be just completely involved in the absence of or the form, not form or the stop codon can lead into absence of mRNA. So if there's no mRNA, there's no polypeptide chain, and if there's no polypeptide chain, no channel. So according to this, there are 6 types of mutations. I mean, just to give some idea, because all the clinical manifestations, all the spectrum, the severity is depend on this type of mutations. Depending on the type of mutations, the clinical spectrum will be changed, because depending on these mutations, the number of functioning molecules, functioning channels, there will be depend on that. So the type 1 is just a simple stop codon leading to no synthesis of the first one, no synthesis of the mRNA at all, so there is no molecules. And type 2 also, the mRNA is formed, the polypeptide channel is the chain is formed, but it doesn't fold into a proper channel, so then there are no channels. And type 4, 5 and 6, the channels are formed and they are going into the apical surface as well, but there are some malfunctioning. Sometimes the channel get not open properly and the number of channels are less. So depending on that, there are different type of diseases. The first 3 are called the classic CF, the absence of the CFTR molecules, and 3, 4, 5, 6, the other molecules or the genetic defects lead into less severe disease, because there are some form of CFTR is available, but there are malfunctions that lead into the disease. This is very important, because now the management of cystic fibrosis depend on these targeted molecules, targeted genetic defects, and finally there are drugs already been invented, and now there are many drugs in the pipeline to directly involve the mechanisms and try to reverse these changes. All these things are depend on the different types of mutations. As I mentioned at the beginning, there are over 2000 mutations, and these different mutations cause one of these 6 types of conditions or the different types of manifestations, and depending on the availability of the functioning CFTR or this ion channel, the clinical manifestations will be, and obviously the outcome will be decided. The commonest one, the very popular one, the delta 5 notate. I'm sure you have heard about this. In delta 5 notate is a type 2 mutation. The polypeptide chain is formed, but it doesn't fold into a proper channel. So without making a proper channel, so channels are not available. So these patients are called the classic CF. It presents in the early part of their life with the features of all the features of complete cystic fibrosis disease. So when we consider cystic fibrosis, is it a disease of West? Yes, initially it was like that. So people thought it's involved in the Western, mainly the Caucasian people. The cystic fibrosis is the commonest life-limiting single gene disorder in the West or the Caucasians. There are many people are affected with this disease. It's a one of the important life-limiting diseases in the West, as their prevalence, it's around 1 in 2,500 live births. So according to their populations, they have very significant number of patients with cystic fibrosis. It's roughly 1 in 2,500. Right? But now, because of this prevalence, increased prevalence in these countries, they have a newborn screening program. For example, United Kingdom, since 2007, they are doing the universal screening for newborns. As you know, they are doing different types of newborn screening. In Sri Lanka also we are doing to identify hypothyroidism, like that Guthrie test. The Guthrie card, the panel includes cystic fibrosis as well. They are assessing the immune reactive trypsinogen level in the or the IRT level in this Guthrie card. If the levels are high in the blood, then they do the further investigations to confirm the diagnostic, genetic and the acid chloride testings. So after birth, within few weeks of life, even the child before showing any clinical features of cystic fibrosis, these countries now they diagnose this disease and start the management as early as possible before developing any features of any clinical symptoms of cystic fibrosis. That lead into very important outcome will be very high. So because of that, now these countries actually there was a dramatical change in the identifications management of this disease. So because of that, in 1970s, the life expectancy of these patients or the children diagnosed with cystic fibrosis in 1970s, even the Western countries, it's around 16 years. That means they don't usually pass beyond the teenage life, and they don't go into adult life. There were hardly very few adults with cystic fibrosis, but now it has been dramatically changed. Now there are many adults. That means children are surviving. They are going to the adulthood with cystic fibrosis. They are surviving, and now in Western countries the median age of survival is 47 years almost, reaching 50. But still you can see it's still a life-limiting disease, and eventually they are dying usually before going into their 16, majority of patients. But now the Western countries, the adult population is more than the pediatric population. The patients with cystic fibrosis, number of patients less than 18 years are now less than the more than 18 years. That means the more people, more children are surviving. Now cystic fibrosis gradually becoming an adult disease in the West. But still in Sri Lanka, still it's a pediatric disease, because majority of these children have poor outcome due to various reasons. Obviously you can see while when you are going through the management, because of late identifications as well as the lack of proper facilities to do the ideal management in our setup. So in West, the delta 5 notate, the F5 notate deletions, that's the commonest mutations, the popular mutations. Around 70% of children or the patients with cystic fibrosis in the Western countries, so the Caucasian, they can found these mutations. But in our setup it's little difference, and usually they do genetic panels 30 to 50 common genes, and majority of them can be identified doing this. As I mentioned, there are more than 200 mutations. So any of these mutations, homozygous state, can lead into cystic fibrosis. But the commonest one in the West is say delta 5 notate deletions. That in the Asia, as I mentioned earlier, initially it was considered as a disease of West. There were no patients diagnosed to have cystic fibrosis in Asia among the Asians. So it's a disease for the Caucasians. But later, with the development, understanding of the disease, many parts of the world in Asia, they have identified patients with cystic fibrosis. And so but obviously, according to the studies, the study populations they have done, the prevalence will be vary. In Jordan, they have identified 1 in 2,500 to in Bahrain 1 in 5,000 like, and Japan little less. number of patients, and this actually even the West, it's more than 70%, so the around 70% of the delta 5 noted deletions, but the maximum is one third, around 34% of patients in the Asia having these common deletions. So why we are missing? So actually the numbers are less, or we are missing? Yes, obviously in comparison to the West our numbers are less, but still there are many issues. Obviously the underdiagnosis in which this part of the world, in the Asian countries, still the awareness of this disease is much less. So because of that, the diagnosis is uncertain, underdiagnosis reporting is significantly low. And there are no obvious registers, national registers to collect all these data. So there is the obvious underreporting, as well as the variability of these mutations, variability of these clinical presentations, variability of the clinical spectrums. All these things leading to underdiagnosis and underreporting of these patients with cystic fibrosis. For example, in Sri Lanka also, the earlier it was not considered as a disease, but now with the understanding, awareness of this disease, we are diagnosing many patients with cystic fibrosis in Sri Lanka as well. That's why this is very important in Sri Lanka to make this awareness, to identify these patients, early suspicious, make them early, support the diagnosis early to prevent the long-term outcome, or at least to delay the long-term adverse outcome. The situation in cystic fibrosis in Sri Lanka. In 1994, the first confirmed case of cystic fibrosis was published in Ceylon Medical Journal. It was diagnosed by Professor Silva. So he has identified a family of Muslim patients, because this disease, surprisingly, the prevalence is high in our setups among this Muslim community. Possibly these genes came through the Asia. They are sharing some common genes, but all the Sinhala, Tamils and Muslim patients, we are patients with cystic fibrosis, but in comparison to the less number of populations, the number of cystic fibrosis patients are higher among the Muslim community. So this child also diagnosed initially, there were two siblings died of respiratory diseases, a chronic respiratory problem in the same family, and another child has been treated as obviously tuberculosis, initial diagnosed and managed as tuberculosis, but then they suspected this child with a similar picture. There's a possibility of cystic fibrosis, but at that time they didn't have the sweat chloride test or other confirmatories, but they did different methods. They used this gel chromatin agar medium to assess this, and finally it's confirmed clinically, and as well as this investigations confirm the diagnosis of cystic fibrosis. So in the 1994, the first case of cystic fibrosis being diagnosed in Sri Lanka and published. Since then, we are having a lot of patients, maybe more than 50 diagnosed or confirmed patients. Many of them have already died up to now during last 2 to 3 decades after diagnosis due to various reasons, especially due to lack of proper facilities to do the management, as well as later diagnosis. At the time of presentations, they are having already established chronic lung diseases and chronic pancreatic issues. Yes, so in Sri Lanka, as I mentioned, we have noticed this special, the ethnic predominant, especially this Moor community, have more genes, especially with possibly some mixing of these genes and with the proper initial common ancestor, and with increased number of consanguineous marriages among this community. And later this publications was came about 10 children genetics identified and published in 2019. In this cohort, they have identified 15% of them have the commonest deletions that found in the West, but our setup is delta 5 notice around 15% of chromosomes identified. And another case, cystic fibrosis Sri Lankan infant, confirmed by genotyping. So this was published in 2015. One child, again, this is the same community with 2 siblings. That's interesting. So this, you can see this family history. Now the father's family, there were 4 siblings died in the early infancy within the first 4 to 6 months of age due to respiratory issues. The father's family. So undiagnosed, most possible these patients undiagnosed children with cystic fibrosis. and this child has been confirmed has cystic fibrosis. Interestingly, you can see in this family tree, four siblings of this child's father died of some unknown, unidentified disease, but they died during the early part of this life. So this child also presented with within first 2 weeks of life with some respiratory symptoms, and later being diagnosed and confirmed as cystic fibrosis, and the genetics genes was also identified. This child had one gene for delta 5 node 8 and other gene. Actually, the parents also assess the delta 5 node 8 came from the mother, and the other gene, it's a little rare genes, came from the father. So it's compound heterozygous. This is an interesting. Usually we know other genetic disorders, especially single Mendelian autosomal recessive transmissions, we need the same gene to as homozygous stage to produce the disease. But cystic fibrosis, any different type of genes which are recognized as CF causing genes can lead into the disease. It shouldn't be the same gene or the same two delta 5 node 8, but delta 5 node 8 or another gene or another different two genes, but if they cause cystic fibrosis, so it's a compound heterogenesis, heterozygous status, and this child also confirmed, this has been confirmed around 10 years ago with cystic fibrosis. But interesting, you can see this family tree, 4 siblings of this father has died early infancy, within first 6 months of their life due to some respiratory problems with possible undiagnosed disease, possible cystic fibrosis. So that's why it's important to improve the awareness. Unfortunately, these children are dying, shouldn't die in the early stages of life. So how do we diagnose? So this is very important. So clinical suspicion is important. Later I'll go through the clinical manifestation of the spectrum of diseases caused by this genetic defects or the molecular defects. And how do we diagnose this? There should be true criteria. There are 2 criteria, clinical criteria and laboratory criteria. We should have either one each from the 2 categories. We should have 1 clinical criteria as well as 1 laboratory criteria. What are these clinical criteria? Siblings with cystic fibrosis. If there's a sibling with cystic fibrosis and if they have positive sweat chloride test, then we can confirm the diagnosis as cystic fibrosis, even the child before developing the clinical features. Obviously, the child is showing clinical features compatible with cystic fibrosis plus the laboratory criteria is there, we can confirm or label as cystic fibrosis. Or the positive newborn screening, or the like doing in other countries, especially the Western countries, increase immune reactive trypsinogen level plus the laboratory, the genetic defects or increased sweat chloride test confirm the diagnosis. And the laboratory criteria, elevated sweat chlorides more than 60 milliequivalent per liter. So here, in sweat glands, as I mentioned, the CFTR, the molecule or this ion channel control the transport of chloride across the cell membrane. So here, it's mainly the net flux or the net direction of this chloride is driven through the concentration gradient. So although the extracellular fluid chloride content is less in other parts of the body, but the sweat gland, the chloride content in the extracellular fluid is very high because there are many other channels in the sweat gland. The purpose is to get these things the out, or as you know, it's a part of regulations or mechanisms which lead into some sort of salt loss as well as to heat loss as a mean to maintain the homeostasis. For that, there are many channels, the sweat glands, which secrete chloride. So because of that, the chloride content of the extracellular fluid is more than the chloride content in the intracellular fluid or within the cell. So because of that, in the sweat glands, through the CFTR channel, there's a net influx of chloride into the cells. When there's a malfunction of this chloride, the influx of this chloride into the cell is reduced. So because of that, the extracellular fluid chloride content will be increased because there are many other channels which secrete, and the CFTR molecule or the channel control this process. When the controller is not there, there will be accumulation of chloride. This is the basis of doing the sweat chloride. So if the gland, practically we are doing is we collect this sweat in the patients. Special gadget is being used is called the pilocarpine ionoporosis. The pilocarpine is insert or some sort of electrical method insert into the the skin, and this pilocarpine stimulates sweat, and then sweat is collected, then the analysis being done. If the chloride content of the cyst sweat is more than 60 milliequivalent, it's confirmed the diagnosis. To confirm the diagnosis, we should have one of these three clinical criteria, because there are some patients, sometimes the cyst chloride level is high but no clinical features of cystic fibrosis. That type of situations are also being reported. So there should be either a sibling with cystic fibrosis, or the clinical features compatible cystic fibrosis, or the screening, newborn screening should be positive. Other is the obviously genetics. So genetic also we can diagnose. So identification or demonstrations of two CCF forming mutations. It might be different mutation, but if these two mutations cause cystic fibrosis, then it's confirmed the diagnosis. And the other one is the nasal potential depressed. Because of these are changes in this ion transport across the cell membrane, the potentials, the potential of this cell membrane, the negative positivity and the electrical charges are maintained through the movement of sodium and chloride channel ion. So as there is a defect in this, the potentials would be different, and there's a specific method to check, but this is not a popular method. That's still the assessment of nasal potential difference is mainly the research level, but practically to diagnose cystic fibrosis, the two most important methods are demonstrations of increased sweat chloride level as well as the genetic defects plus the clinical criteria. If both are present, one from each category, that's confirm the diagnosis of cystic fibrosis. In Sri Lanka, we have the facilities to do sweat chloride level. We would like to grateful to establish this service by Dr. Iresha Jashinger. She was the former chemical pathologist, worked at LRH. So she initiated this assessment of sweat chlorides available in LRH. This is the only place available in Sri Lanka. And recently also we got new machines through a donation. And the genetics tests are also available in Sri Lanka, as well as the genetic panels in other countries, especially the Asia, because it's a huge gene. We cannot assess all the spectrums, but we are doing some suspected, or maybe sometimes we have to do the whole exome sequencing to identify the molecular defects. With this background, so what is the presentation? This is the most important thing to focus. As I mentioned, this primary problem is in this molecule. It's not a simple molecule. It's a very complex molecule which control the chloride transport across the cell membrane. Actually, the problem is not the chloride. When the chloride transport is get abnormal, it's affected. It's involved the sodium transport. Sodium transport is affected. It's involved in the hydration of the luminal surfaces. Finally, the effect is to increase thick secretions in these luminal surfaces of these many of the glands, the ducts, involved in the various organs. So then that's leading to the obstruction of these organs, and finally leading to the spectrum of clinical manifestations. Depending on the organ involved, this clinical spectrum will be different. So from the beginning, since birth, we can see some children are presented with effects of cystic fibrosis, or it may be diagnosed at just after birth, or even very late in their life without any problem initially, and only manifestations is subfertility in male or infertility in male. When the investigations were done to assess the subfertility, then can identify the azoospermia due to cystic fibrosis. So since early part of life, since neonatal period, within first 2 days of life to later part after marriage, till that this clinical spectrum presentations and the age at onset of these symptoms or the clinical manifestations will be differ in cystic fibrosis. That's all depend on the organ involvement and the spectrum and the degree of this organ involvement. So the first clue for the diagnosis of cystic fibrosis in just after birth is meconium ileus. What is meconium ileus? As you know, the meconium of these patients with cystic fibrosis become thick. So because of that very thick meconium, the infants are unable to pass this meconium. It's mainly affecting the distal ileum just before the colon. And because of this impaction of this meconium, the distal bowel or the large bowel also get atrophied. And after birth, they are presented with evidence of intestinal obstructions, bloated abdomen, biliary vomiting, the persistent vomiting, as well as the delayed passage of meconium. So the impactions of the meconium within the small intestine, especially the distal ileum, leading to meconium ileus. It's initially the functional disorder because of this thick meconium leading to the obstructions and the management. Sometimes even just a gastrographic enema or the contrast enema. Because contrast gastrographic or the contrast we are using for the radiological investigations, they have high osmolarity. Because of this high osmolarity, they can absorb more water into the lumen, then that's leading to the reduce the thickness of this meconium, and it's facilitate the passage of meconium and reduce the or alleviate the intestinal obstructions. But sometimes or majority has to undergo surgical procedures. Sometimes they might need the resection of the part of the bowel in complicated cases. Sometimes there might be bowel rupture. So if a child diagnosed to have meconium ileus, it's very, very important to investigate for cystic fibrosis, because 80 to 90% of children with meconium ileus, the reason is cystic fibrosis. In cystic fibrosis, children with cystic fibrosis, the patients with cystic fibrosis, the prevalence or the chance of having meconium ileus is 15 to 20%. Only 50 to 20% develop the meconium ileus. But other way, the people or the children or the newborn who are coming with presenting with cystic fibrosis, there are 80 to 90% of them, the reason is cystic fibrosis. So that's why it's very important. All children diagnosed to have cystic fibrosis, diagnosed to have meconium ileus, should be further evaluated to exclude cystic fibrosis, but most of the time they should have cystic fibrosis. And our setup also, there was one child confirmed diagnosis of cystic fibrosis, later initially presented at Peradine or Silva Bandaranaike hospitals, now being follow up confirmed child with cystic fibrosis. So it's one of the important clinical manifestations, clinical presentations, initial presentations. First few days of life, we can suspect possibility of cystic fibrosis in children or newborn presenting with meconium ileus. And then the prolonged neonatal jaundice. That's one of the recognized manifestation of cystic fibrosis, but it's a rare manifestations, and even in our setup we have any child presenting as prolonged neonatal. It's an obstructive type jaundice involving the liver involvement and obstruction to this biliary tree, obstructive jaundice. It's another recognized manifestation of cystic fibrosis. If a child has prolonged jaundice or the increased conjugated hyperbilirubinemia, one of the important differential diagnoses is cystic fibrosis. And then, as you know, one of the important manifestation of cystic fibrosis is this exocrine pancreatic insufficiency. The pancreatic duct, the cells lining the pancreatic duct also contain this the ion channel. So it's important to maintain the hydration, reduce the viscosity of these pancreatic secretions, or the pancreatic, as you know, the pancreatic secretions are the enzymes. So if in the child with cystic fibrosis, the hydration of these luminal surfaces get involved, so then less hydrations, more thick fluids or the enzyme containing these fluids in the pancreas, and leading to the obstruction of the pancreatic ducts and leading to the absence of these enzymes into the gut. So the net effect is malabsorption. So because of the lack of pancreatic enzymes, as we know, there are three types of pancreatic enzymes: lipases, amylases, and proteases. These are essential for the digestion of this food. So then the lack of absence, sometimes completely absent, so the lack of this pancreatic enzymes in the gut finally end up with malabsorption. Those children are again presented with features of malabsorption. The steatorrhea, as very popular, as you know, the oily stools, sometimes greasy stools, difficult to flush from the toilet, is sticky and foul smelling, and they are having some other diarrheal and the other bowel involvement as well. All these features are leading to the malabsorptions, and obviously end up with significant failure to thrive, malnutrition, and features of even later vitamin deficiencies, even especially the fat soluble vitamin A, D, E, K deficiencies also they can have in the late in life due to fat malabsorption. So it's one of the important clinical manifestations. If a child presenting with features of malabsorption, especially if evidence of steatorrhea, if the mothers complain this child's stools are very greasy, very oily, it's difficult to flush, and sometimes they are floating in the toilet, then they always have a suspicion of possibility of cystic fibrosis malabsorption in this child. The confirmation of diagnosis is to assessment of the stool elastase level it's available in private sector, not in the government sector. So elastase, again, the protein, and with the it's an enzyme, that's a protein with action of elastase also important enzyme, but then that also digests through the when it is going through the small intestine, and we should not see significant amount of elastase in the stools. But if the stool elastase level are high, that means there is a problem with digestion. So that's confirmed the malabsorption. That could ideally, the gold standard test to confirm malabsorption is to collect stools for 72 hours, 3 days, and assess the fat content. That's a gold standard, but as obviously it's very difficult and cumbersome to collect the stools for 3 days and collect these stools and do the analysis. So because of that, it has been completely abandoned. But now this method is there. Assessment of stool elastase level confirm the diagnosis of malabsorption, and then we have to think about the possible cystic fibrosis. Need to do further investigations and evaluations. Respiratory involvement, this is one of the key. That's why there is a major involvement which lead into the significant morbidity as well as eventual mortality. So the main important manifestation of cystic fibrosis is this respiratory involvement. That's why the respiratory physicians came into this management of these patients, and finally the CF become a respiratory disease because of this. The major issue is again same. So it's very important to have adequate hydrations, adequate amount of water within the luminal side of this airway, because airway contain the mucus. So this mucus are very important to get rid of these organisms, because we inhale various pathogens, organisms, other particles, dust and toxins, materials, various things we inhale. As we know, we inhale in the adult. If we take adult, we 24 hours we inhale about 10,000 liters of air. Actually, we don't think about that. For the survival, we need 2 to 3 liters of water per day. But for the survival, we inhale without our notice around 10,000 liters of air. With this 10,000 liters, various pathogens, toxic materials, various pathological or the toxic, the materials can be inhaled with the same time into the lungs. But there are, as you know, the proper ciliary mechanism is there, and it prevents or they enter into these organisms and these materials. But with the malfunctioning of this system, especially the increased thick secretions leading to malfunction of this, the very advanced mucociliary escalator, these clearance mechanisms, and finally end up with significant respiratory diseases, obstruction of this airway, mucus plugging, especially very thick viscous mucus plugging, and finally end up with recurrent chest infections and involvement of a respiratory tract, finally end up with bronchiectasis. All these things are leading to this increased thick secretions in cystic fibrosis, and finally end up with severe significant lung damage. Initially they present with recurrent episodes, exacerbations, infections, and finally lead to significant bronchiectasis. And you can see this significant lung damage associated with this cystic fibrosis, finally end up with hypoxia and pulmonary hypertension and copulmonale, and finally death due to this unfortunate disease of cystic fibrosis which involve the lungs. And failure to thrive. This is one of the important manifestations. Sometimes the only clinical manifestations of cystic fibrosis would be failure to thrive, very poor weight gain. So we have diagnosed many children before development of the respiratory involvement, and sometimes they might not show obvious evidence of malabsorption also. They don't have much of the diarrhea or the steatorrhea, but failure to thrive, unexplained failure to thrive, we have to think about cystic fibrosis. All the 4 mechanisms which possibly leading to failure to thrive are implementing in cystic fibrosis. Obviously, the intake would be poor due to their recurrent infections, recurrent respiratory involvement, and they are usually ill, and they are having these diseases going on. So all these things finally lead to poor food intake, loss of appetite, increased energy intake, and then absorption issues. Obviously, is associated with malabsorption, and then the demand. So they having some respiratory problem, increased respiratory rate, increased metabolic demand. So because of that, expenditure is increased, intake would be reduced, absorption is reduced, but in top of that the demand is increased. So because of, obviously then the demand is not compatible with the intake, so because of that leading to the significant failure. In addition, the sold loss through the skin leading to again aggravate these conditions because it's metabolic involvement. So it's a complex process and finally leading to the development of disease. The pseudo-Bartter syndrome, it's a involvement of the, yes, as you know, Bartter syndrome is a sword loss. The problem in the channel, in the distal lumen, the loop of Henle, and leading to sword loss through the urine. It's called the Bartter syndrome. It's developed metabolic alkalosis, and the same metabolic dearrangement happens in cystic fibrosis, but there's no urine loss, but the same sword loss is happened through the skin, through the ion channel. So as we discussed already, the chloride content is high in the sweat and the chloride absorption is reduced, so because of that sodium absorption is reduced, so because of that we lost this sodium chloride through the skin. That leading to reduced sodium chloride content in the body like Bartter syndrome, but this is pseudo-Bartter because it's not true sword loss from the kidney. So they have hypokalemia, hypochloremia, metabolic alkalosis without evidence of renal tubulopathy. So it's pseudo-Bartter syndrome. So then, yes, this is the reason to these patients having this very salty skin. This kiss of salt, finally cursed and death due to these children. Yes, this is the reason to they have the very salty skin. And even in 1951, Dr. Dorothy, the person who has identified the cystic fibrosis, the coined the name of cystic fibrosis of pancreas, she also identified, they published this case during in USA during the summertime with some heat waves, children with who had developed the heat stroke, the heat complications due to heat, and they had children, high prevalence in children with this disease was being initially termed as cystic fibrosis of pancreas. Again, this is associated with this sword loss. And there are many different spectrum of gastrointestinal manifestation of cystic fibrosis. Sometimes they might have rectal prolapse. It might be another initial important clinical. Sometimes it might be the first manifestations of or first clinical presentation of this disease. And distal intestinal obstruction syndrome. Again, obstruction of the distal intestine, especially the distal ileum. This is again the functional disorder. Increased thick stools leading to obstruction of this bowel, and sometimes this might be the first presentations if this is a child developing a child who has not been diagnosed as cystic fibrosis and obviously end up with in surgical wards as intestinal obstructions and obviously will undergo surgical procedures. But most of the time in the children, if it is distal intestinal obstruction, if it is cystic fibrosis, it's a functional disorder. Majority can be relieved with the gastrography or the contrast enema that reduce this thickness and it facilitate the movement of this inspirator stools or the impactor stools in the small actually not the stools that part of that the gut content, and that relieve the absorption. No need to do majority in the distal intestinal obstructions. Majority they don't need surgical procedures, but unfortunately sometimes in the first presentation would be obstructions and end up in surgical units undergoing unnecessary because of lack of diagnosis. Obviously have to do some surgical procedures if it's not being diagnosed, as this first presentation would be sometimes end up with explorative laparotomies in these children, even sometimes resection of bowels. So this is one of the important manifestations of intestinal obstruction. And sometimes increase in small intestinal bacterial growth, imbalance of bacteria in the small intestine. Sometimes they face bloating of gases like bloating features and evidence of increased bacterial colonizations, again associated with disease. So pancreatitis is one of the important manifestations, especially children with pancreatic sufficient cystic fibrosis. 15 to 20% of patients with cystic fibrosis do not have pancreatic insufficiency. These patients also might have some degree of involvement of these pancreatic ducts and finally end up with pancreatitis acute, as well as most importantly, they might suffer with recurrent episodes of pancreatitis that lead into chronic pancreatitis, very very debilitating disease, and finally involved in the damage to the pancreas as well as calcifications and long term very very poor outcome. And as you know, it's a very painful disease. There are children suffering from this disease. So this is one of the important clinical measures. Any child presenting with pancreatitis, we have to think about possible cystic fibrosis, because these children might not have evidence of pancreatic insufficiency. That's very important. And liver diseases, there's a wide spectrum of liver diseases involving the cystic fibrosis. And finally, these children can progress to development of cirrhosis associated with portal hypertension. There will be biliary cirrhosis, cholangiostasis. All these things are related to obstruction of these the ducts as well as the biliary system. And fertility issues. So this is a very later manifestation. Sometimes the patients with less severe disease, initially they don't show any evidence of respiratory involvement or the features of malabsorption, so metabolic disease, but later they might present with evidence of subfertility, or actually they are infertile. So when this assessment is done, sometimes identify, because this is against obstructive azoospermia, there are vast difference. They are obstructed due to against the same pathophysiological mechanisms, and even the production of sperm is there, but obviously there is no ejaculations due to obstruction of this ducts. So then finally it end up with subfertility. Even this can happen in females, then lead to thickened cervical mucus in these patients. And endocrine manifestations later in their life, CF related diabetes. So it's again important, especially these later manifestations. The initially in cystic fibrosis, the pancreatic involvement is exocrine pancreatic deficiency, especially reduce or lack of these enzymes, and later gradually the pancreas get damaged, fibrosed, calcified, and then gradually the beta cells population also decrease or the reduced number, and finally leading to the endocrine pancreatic insufficiency, and obviously leading to the diabetes, cystic fibrosis related diabetes. Children who has been already diagnosed as cystic fibrosis after their 8 to 10 years of life, routine assessment of diabetic status, so the sugar levels are very very essential. And the pubertal issues, growth issues, hypogonadism, bone diseases, all these related can be found in children with cystic fibrosis. They are multifactorial, associated with different reasons, the metabolic as well as gut and bowel involvement and various other system involvement. So how do we manage? So this is a challenge, right? There are many new development across the world to reduce the morbidity and mortality of these patients and improve the quality of life and the life expectancy. Various objectives are there. We have to facilitate their lung growth, allow them to have near normal life. Might be very difficult, but as much as possible to allow them to have near normal life, prevent exacerbations, prevent hospital admissions, and the progressions, delay or prevent. Might be very difficult to prevent the progression, but as much as possible we have to delay these progresses, as much as possible allow them to have near normal life. So this is very important, and so with minimum or no side effects of these medications. So it's very important. Yes. So one of the important managements, I'm just go through this little quickly to assess the principles of management, because it's some of these things are highly advanced technical things, but importantly the airway clearance is one of the cornerstone of management of children with cystic fibrosis once they shows evidence of established bronchiectasis or airway involvement. As I showed earlier, the primary problem is increased thickness of this mucus, the thick viscous mucus leading to obstruction of this airway, finally leading to this damage associated with this cycle. So bronchiectasis cycle. So inflammations is leading to the damage to the airway, and damage to leading to the bronchiectasis, and this bronchiectasis further leading to accumulation of this mucus, and this mucus act as a culture media. The more organisms will be grown in here, and finally lead to infections, and this inflammatory process produce various cytokines, various cells produce proteases, and this inflammatory process itself leading to the damage to the airway and the lung, and finally end up with bronchiectasis. So the infections, inflammation, bronchiectasis, this cycle will continue as a vicious cycle, and finally end up with this type of severe changes and significant lung damage. And this sometimes their lungs, they have lakes of mucus, significant dilatation of this bronchi, and finally leading to the hypoxia, and then hypoxia chronically leading to pulmonary hypertension, and then end up with copulmonary, and finally uneventable death in these patients. So airway clearance is important. As much as possible, you have to get these things out, this mucus out, to break this cycle. The easiest, the most effective and the practical way of breaking this cycle is to get these secretions out as much as possible with the various airway clearance techniques are there. There are independent. The patient himself allowed to drain using the gravity, depending on the lobe involvement, various positions are there. This is called the postural drainage, depending on the lobe involvement. The segmental involvement, different positions are there to get the gravity assisted drainage. But the advantage is nothing is necessary just to change the posture only, but disadvantage we have to keep a little time. It will take time. We have to in that position. We have to allow some times, maybe half an hour, maybe more than that, to drain the necessary segment. So because of that, there are some techniques. The percussion techniques facilitate this. So this by percussing, what we try to achieve is, we try to break this mucus, disintegrate this mucus and propel this mucus into the proximal layer. Once the mucus reaches the proximal airway, then the child should be able to cough it out. So the percussion techniques are important. Various methods being used. What is called this chest physiotherapy. Mainly we focus on the chest physio, but there are various methods to clear this airway, and there are gadgets. There are some to achieve the same effect. We have percussions, we try to generate some percussion wave, and this wave is transmitted through the chest wall into the airway, break this mucus, and the same thing can be achieved using these gadgets called the oscillating PEP devices, for the positive expiratory devices. The need to just to blow to this device, very easy, and while blowing it generate positive expiratory pressure, it produce some resistance to the air flow, expiratory flow, and it produce some vibration. There are various mechanisms vibrating. Some gadgets contain vibrating magnetic bolts, and this vibration transit back into the airway and directly lead into the breakdown of this mucus. So this is very easiest method. Some of our patients are using these devices. Some of you may have heard about these a cappella devices, aerobica devices. All these things, the principle is same. They are called oscillating positive expiratory pressure devices. Various gadgets are there, various brands, PEP devices, Clutter. Yeah, and there are some advanced machines that simulate the same thing that done by the physiotherapists. The percussions through the jacket wrap around the chest, and this is oscillating with a very high frequency, and that simulate the same percussion effects and facilitate that's called the VEST devices, or the high frequency chest wall oscillation devices. And the same effects we are assessing with our setup with the bottle PEP. Use the bottle, the 10 centimeter water, though you have to blow against this 10 centimeter water resistance, and this while blowing it generates some bubbling. So this bubbling leading to formation of waves, and these waves transmitted back into the chest, and so affect the same thing as we are doing the percussion techniques. We have all our children with chronic lung diseases being used this technique. And there are some junts, or some of these nebulizing devices, dry powder inhalers, to reduce the viscosity of this, or break down the mucus, especially the DNases. DNases are there, they break or the pulmozyme, which break the DNA of these cells, because as you know the mucus contains a lot of cells. They break the nuclei or the DNA of these cells, and while breaking the cells, this break or disintegrate this mucus and facilitate the drainage of this mucus. So various unfortunately we don't have this. We use the hypertonic saline. Our setup here is in 3% saline. Other countries they use 7% saline. Again same thing. This hypertonic saline, or even inhaled mannitol, they absorb more water into the lumen. The primary problem, as we discussing again and again, reduce this chloride content, reduce the water content, sodium content, and then finally reduce the water content of this lumen. So these osmotic agents absorb more water into the airway, and that facilitates reduce the thickness of this mucus and facilitate the drainage or expulsion of this mucus, or the clearance of this mucus. And we are using some immune modulators currently. The azithromycin, the macrolides, they have various functions. They are immune modulators. They are not immune suppressants. Obviously, it's an antibiotic, but they have various effects involving the various cellular pathways. It reduces excessive immune response. As I mentioned earlier, because this major damage to the lung is driven through this immune pathway, immune mechanism. So this exaggerate immune response is reduced by this macrolide, especially azithromycin. and act as an immune modulator to reduce or prevent the development of bronchiectasis or this damage to the lung. So nutrition is important. Obviously, as I mentioned, various reasons because of the lack of intake, lack of absorptions, increased demand, and metabolic damage. All these leading to significant failure choice. So nutrition is important. Growth is important. Various different sometimes other countries even teens they insert gastrostomies to provide extra calories. Especially there are some formulas with high calorie and high protein formulas. While sleeping through the gastrostomy, they provide these nutritions to the support or the match the gap of the intake as well as the demand. So with these things, because the growth is very important, especially children, malabsorption, malnutrition, poor growth, failure, right? It worsens the conditions. It increases the morbidity as well as finally the mortality. And the pancreatic enzyme supplementations, obviously, cystic fibrosis in patients with pancreatic insufficiency, we have to provide. It's a must. As we are telling to patients, no point of taking meal without taking these capsules. It's very important. Otherwise, no point of, there's no absorptions. Very hard, the absorption would be minimum. So if you want to get the nutrition, if you want to get the effect of this food intakes, so pancreatic enzyme supplement is a must for children with pancreatic insufficiency. About 80% of children with cystic fibrosis are pancreatic insufficient. So lifelong replacement with pancreatic enzymes according to the weight we are assessing, or it's contain all the three enzymes, amylase, lipases and proteases. They have to take, it may be just before meal, at the mid of meal, or just after meal. All three methods are okay, but every meal let's just except some sugary or water content or some fruit juices like thing which doesn't have much of the nutrition, but every other food should need, otherwise no point of these taking these foods without replacing this pancreatic enzyme, otherwise there's no absorption. So monitoring is important. As a long-term disease, chronic disease, there's no cure for the disease at the moment, except some cases will come to that. So we have to monitor them. Growth monitoring is important. We have to assess their pulmonary functions. There are various methods we use. Spirometry, sometimes assessment of systemic walk distance to assess their exercise intolerance, exercise tolerance, their endurance, and depending on the clinical manifestations, there are other types of assessment of pulmonary functions. Imaging is important. We have to do frequent chest x-rays, the frequency and depending on the child's general conditions, sometimes more imaging, maybe CT tests, angiograms if they are presenting with hemoptysis, depending on these complications, VQ scans, various types of scans or imaging are there. We have to do them frequently depending on the clinical manifestation, severity of the disease to assess, to prevent the complications, early recognition of import. Microbiologically, obviously, it's a disease which microbiological colonization, especially pseudomonas. Once the pseudomonas is colonized, it's very difficult to get rid of this organism. So the frequent identifications and early treatment, sometimes we have to use long-term nebulized antibiotics. Unfortunately, we don't have these nebulized antibiotics. Other countries, they use long-term nebulized tobramycin, nebulized with aztreonam, or like that. So continuous, every other month they are using nebulization to reduce this nebulized antibiotics, to reduce this morbidity associated with this colonization. And is actually when the organisms are, they continuously produce, continuously stimulate the inflammation that leading to poor outcome and finally lung damage. And again, monitoring of complications, echocardiography to assess development of pulmonary hypertension, sleep studies to assessment early identification of hypoxia, liver scan, blood sugar is essential. As I mentioned earlier, later they can develop endocrine pancreatic insufficiency. Sometimes they can have ABPA or the allergic bronchopulmonary aspergillosis. So one of the predisposing conditions, cystic fibrosis, aspergillus sensitization lead to again chronic lung damage. Pubertal assessment, all these things are important. And the functional impairments, schooling, social aspects, psychological aspects, those are life-limiting long-term disease. They have to, long-term, regular chest physiotherapy. So all these things lead into some psychological issues. Sometimes these children, they refuse. They don't do chest physio airway clearance. So it's very difficult, very important to get them on board to our management plan to get a proper outcome. And now, all these methods I mentioned just to support the management, it won't change the disease. There is no cure for up to last 2 to 3 decades. But now, for some patients with some mutations, now cure is possible. But still, again, same thing, we have to continue these medicines. But at least to reverse these changes of primary molecule layers, there are some drugs now developing, already developed, still in many are pipeline to reverse the channel abnormality, reverse the molecule abnormality, reverse the primary problem, to reverse or prevent the development of complications. So there are different types of medications. There are potentiators and correctors. Potentiators improve the CFTR as well as the correctors. Sometimes they can completely correct, and some patients after taking these medicines, the set chloride levels become negative, their pancreatic pancreatic insufficiency becomes sufficient, or their stool elastase level become normal. That type of miracles can happen, but these are very, very, very expensive. For example, to provide these medicines in Sri Lankan setup, it will take around 4 to 5 millions per month. So expensive. But now through some donations, so through NGO, we are trying to get down some of these drugs. But importantly, these drugs, all drugs don't mesh or they work for all people. There are specific mutations, it's work. But still, there's a hope. There are many medicines now developing and in the market or becoming popular, which can reverse the primary problem in cystic fibrosis. And finally, if the respiratory involvement is going on, then the respiratory support is important. At the later part of this life, our aim is to prevent or delay this oxygen requirement as much as possible. But unfortunately, if they have significant lung damage, especially the diagnosis, if the diagnosis is delayed, then they end up with bronchiectasis, hypoxia, early part of this airline. Then sometimes we might have to give home oxygen, sometimes home NIV through the concentrator or the oxygen cylinders. It's a part of the long-term management of this child. But as much as possible, we want to prevent, we want to delay the requirement of oxygen in these patients. So in summary, cystic fibrosis is the commonest life-limiting genetic disorder in the West. Initially, it has not been considered as a disease in Asia, but now it's been recognized. Still, the problem of underdiagnosis, under-recognition, under-reporting, but still there are many patients with this disease. In our setup also, we have confirmed cases. Now 50 cases, some of them are unfortunately died, and many of them, some children undiagnosed in the family. Some, as I shown earlier, many children sibling deaths and undiagnosed, and then later we diagnose these patients, the current sibling as a cystic fibrosis. Possibly the early neonatal death of these patients are possibly due to cystic fibrosis. So it's a multi-system disease due to involvement of the CFTR gene, leading to the malfunctions of the cystic fibrosis transmembrane conductance regulator ion channel, which is a chloride channel, which is important to maintain the hydrations in the lumens of many of the important organs involving the lungs, pancreas, the vas deferens, and many other organs, especially which involve or give rise to long-term morbidity. So the clinical presentations will be wide spectrum depending on the involvement of the organs, and so this obviously causes significant morbidity, long-term disease, chronic disease, life-limiting disease, and yes, obviously finally end up with eventual mortality. So it's because of that the prevention or that the delay the progressions, early diagnosis, clinical suspicions, keeping the awareness about the possibility, existence of disease in our setup, Sri Lanka as well, to think about cystic fibrosis, undiagnosed, unexplained respiratory manifestation, bowel manifestations. Think about possible cystic fibrosis when the child is having significant failure try without obvious other organ involvement. It would be child with hidden cystic fibrosis. We have many patients diagnosed to have, and we have started even before doing sweat chloride test, pancreatic enzyme supplementations, and some children are doing well even before the diagnosis of the confirmation of the disease. So it's long-term interventions, getting their on-board explanations, making them the families support, and is important. So early diagnosis is very, very important, and the proper management plan is important. So miracles do happen. It's important to get them identified, diagnosed, and you can see this a child with cystic fibrosis initially had significant failure tribe, and then after diagnosis, this has been clinically diagnosed before doing the sweat chloride test, before doing the genetic testing, later confirmed, and you can see the dramatic improvement in the weight and going in the fairly good weight. So this type of things are present with the early diagnosed clinical suspicions and the thinking or the identifying the existence of this disease in even though it's unfortunate in Sri Lanka as well. So your support, your adequate referrals are important to reduce the morbidity and mortality of this disease and to improve the identification of disease in Sri Lanka. Thank you.
So now we've come to the part of the session where we'll be answering the questions. Sir, the first question is, how often is cystic fibrosis misdiagnosed in Sri Lanka, and what are the common conditions it is mistaken for?
Yeah, can you hear me?
Yes, sir.
Yeah, okay. So, how often misdiagnosis? Again, it's the same thing. Still, we don't know because misdiagnosed patients are they won't come to us. So that's the issue. But the thing is, sometimes we are diagnosing these children little later. A few manifestations. One is failure try. Sometimes they are having persistent failure try without any clue, and that of time without any evidence of malabsorptions, overt evidence of malabsorption, no respiratory diseases. That type of situations the diagnosis would be missed, and we have diagnosed few patients and they just uh, um, the growth chart this I have shown again. That one also we have suspect as possible cystic fibrosis because that one had very significant failure trend. We started pancreatic enzyme supplementations, dramatic improvement, and then need the testing because to do the set chloride testing, child should have weighed at least above 5 kilograms. Otherwise, it's difficult to get the proper set collections. And obviously, to do the genetic testings, we have many limitations. Only the delta 508 is available in the widely our setup. That's also in the private sector, but our mutations are little different. Our mutations, the rare mutations. So for that, we have to get the overseas. So some sophisticated genetic assessment. So that type of things the confirmation is getting delayed, and other one is obviously children present with recurrent respiratory tract infections, evidence of persistent respiratory tract infections, as well as evidence of chronic lung diseases. That type of children, obviously, yes, we have to suspect cystic fibrosis in our setup. And as I mentioned, one case we have diagnosed presented with meconium milis. That time, anyway, if you see a child with meconium milis, obviously we have to do the further investigations to rule out cystic fibrosis.
All right, so the next question is, sir, how do you give fat-soluble vitamins to a neonate with cystic fibrosis?
Yeah, thing is, yes, that's an important thing. First thing is, yes, so there are some practical issues, especially first thing is before giving the vitamins to give the pancreatic enzyme supplementations. So we have the capsules, and this within the capsules contain some granules. So we break the capsules and calculate the number of granules and provide this enzyme, pancreatic enzymes. But vitamin supplementations we can give. There's no issue with that, and doses also we adjusting according to the child's age and weight with available vitamins. Sometimes there are some practical situations. The thing is, these children, once we diagnose, we have to manage them individually. So we cannot say this is the amount, this is the amount. For example, pancreatic enzymes, we are giving 1,000 to 3,000 units of lipase per kilogram per main meal, and then half of that for the snacks like that. But we have to adjust these. Sometimes we have to go up to even 5,000 units per kilogram per meal like that. These things are sometimes we have to do some trial and errors to get the final is a clinical assessment, long-term assessment, long-term follow-up to identify what is best for these children. So the vitamin supplementation also same. We have to provide the vitamins as well as the double the doses of the water soluble vitamins as well. Even this problem is associated with fat absorptions, fat malabsorptions, and the fat soluble vitamins, but water soluble vitamins also we are supplementing.
All right, sir. The next question is, are there any vaccines given as prophylaxis for cystic fibrosis?
Yeah, basically, there's no specific vaccines for cystic fibrosis, but when they develop recurrent respiratory tract infections, because there's a chance risk, any child to prevent the common respiratory infections, we can give the only available the pneumococcal vaccines as well as the influenza vaccine, which is very common these days. Only those two are available, but otherwise, no other specific vaccines, especially for CF patients.
All right, sir. What are the implications of antibiotic in long term for patients with cystic fibrosis?
Yeah, that's again depend on the degree of lung involvement, development of the lung damage, especially development of bronchiectasis. Bronchiectasis per se is not an indication to start prophylactic antibiotics, but we are using this azithromycin or the macrolides as an immune modulator. That's a different thing. Here, the function is little different, as I mentioned earlier. That's not we are using not as an antibiotic, as immune modulator, because there's a specific action. There are different types of actions with macrolides. These macrolides act on various immunological pathways and prevent this excessive immune response. And that they act as immune modulator. That means they are not immune suppressors. They not produce immune suppressors, but macrolides have specific activity. So because of that, we are using. So here, our setup is azithromycin, 10 milligram per kilogram, 3 days per week, Monday, Wednesday, Friday. That's as an immune modulator. But prophylactic antibiotics, again, when they develop bronchiectasis, when the bronchiectasis is going on, they trigger chest infections, that type of situations, we start prophylactic antibiotics. Other thing is, the most important thing is, it's very, when the some sort of organism, especially Staph aureus, MRSA, and Pseudomonas, when these organisms get infected or they have become chronic colonizers, but it's not, they are not, that means that just simple colonizers. When they are there, that means they produce some sort of infections. The inflammation process will go on. Even the child doesn't show any evidence of acute pneumonia, acute infections, or overt evidence of infections, but still the inflammatory process subclinical will go on. So because of that, we have to use long-term antibiotics to eradicate as much as possible to these organisms, especially Pseudomonas. For other countries, they are using nebulized antibiotics. There are at the moment three: colistin, tobramycin, and aztreonam. These antibiotics every monthly alternative, sometimes few years, have to continue. So that type of situations, yes, you have to use some antibiotics. But prophylactic antibiotics, again, depend on the clinical situations. But most of the time, when they have these chronic long-term colonizations with the organisms, depending on the ABSD, we have to use some long-term treatments. The classic example is use of these nebulized antibiotics, aztreonam, colistin, and tobramycin as nebulized. So there are specific gadgets they use, not our usual jet nebulizers, small nebulizers. Within 30 seconds, they can inhale alternatively monthly, because as you know, when you use an antibiotic long term, obviously there's high risk of developing resistance. To prevent that, they change the antibiotic.
The next question is, what is the referral pathway in Sri Lanka if cystic fibrosis has been suspected in a patient?
That's good, yes. So first thing is, if you suspect or in a primary care setup, better refer to a nearest pediatrician, available pediatric clinic or PDs, or the tertiary care center, or even base hospitals where the pediatric services are available. What is that? Once the pediatrician is suspecting cystic fibrosis, usually they refer to us. Oh, now pediatric chest physicians are in LRH. We are doing the service. Karapiti hospitals, Peradeniya, Jaffna, even now Rantapura, Badulla, except Batikulo, every province except the eastern province, now every province in the main tertiary care hospitals, pediatric pulmonaries are also available. Can refer directly to these clinics as well.
The last question is, sir, they would like to know more about the nutrition management in cystic fibrosis.
Yes, obviously. Yeah. So cystic fibrosis is one of the important conditions with leading to malnutrition with all the possible mechanisms. All four possible mechanisms are there. Their intake is poor, their absorption is poor, their expenditure is high, as well as they have salt loss. All these four mechanisms can lead to poor weight gain, poor growth. Yes. First thing is, have to, yes, it's not a time to discuss the details about the nutrition management or going into the details about the nutrition. But obviously, first thing is we have to supply or provide pancreatic enzyme. which is essential to improve the absorption. Otherwise, as I mentioned, no point of giving foods without enzymes, because if they have the pancreatic insufficiency, we are using there are capsules, 10,000 international units. It contain all three enzymes, uh, pepsin, pancreatic three enzymes, amylase, lipase, and the pepsin. So all these to digest protein, carbohydrate, and lipids. It's essential to provide with every meal. That's one of the important. Then the nutrition content. So again, depending on the child's age, weight, and other factors, we have to improve the nutrition, give adequate amount of foods, increase calorie intake, as well as maintain their pancreatic enzyme supplementations to make sure these things are get absorbed. And then other rest of the things, nutrition with the physical activities, and to treat the underlying diseases, underlying respiratory conditions, because that's increase the metabolic demand expenditure. So for that aspect also, so for nutrition overall, we have to address different aspects, not only just simply providing meals or the nutrition foods, but there are different aspects, because all the mechanisms leading to the poor nutrition, poor weight gain, and finally poor outcome is these patients with cystic fibrosis. But other thing is, we should not that's so obviously when we are giving fat containing foods, the stool bulk will increase. It's become more foul smelling like that. Then sometimes the parents might not be a, tend to give fat content foods because of this. It's not only the fat malabsorptions, but most important thing is to give adequate amount of these pancreatic enzyme supplementations and give the foods as usual, as in like giving adult, other children, and maybe little more to cover the or demand the metabolic demand, and we should not restrict fat foods. So that's another important thing.
So there's another question. What advices will we give parents with a child with cystic fibrosis in regards to their next child?
Yes, obviously it's an autosomal recessive disorder. As you know, there's a 20% chance of having the disease, and we have one family, two children are affected, and one there's healthy child, and sometimes yeah. So it's again same. It's normal genetic counseling as per a simple. Autosomal recessive disorder, 25% chance is there. That's the main risk, and others become 50% become carriers, and another one fourth of the child, 20% become completely normal children. The same simple genetics is here applied here as well. So it's a usual genetic counseling. There's no specific thing, but it's because it's a single gene, simple Mendelian inheritance autosomal recessive disorder.
All right, thank you, sir. We've come to the end of the question session. So, on behalf of Society for Health Research and Innovation, I would like to sincerely thank Dr. Channa de Silva for his excellent lecture. And we're hoping sir would be working with us for our next CPD programs as well. Thank you, sir.
Thank you. Thank you very much.